Hi, good morning, doctors. Today we are on our fifth day of reading Oxford Handbook of General Practice. We are at page number 217, and lastly we have discussed about nighttime ABPM and why it is important. So next is home BP monitoring, HBPM, useful. If ABPM facilities are not available within a reasonable time frame for diagnosis of hypertension, for patients who cannot tolerate ABPM, for monitoring of antihypertensive treatment. Instructions. Patient should use a validated and calibrated BP machine. Measure the BP on at least 4 and preferably 7 consecutive days. Measure the BP 2 times a day, morning and evening when seated, and take 2 readings more than 1 minute apart every time. Discard the readings taken on day 1 and take an average value of all the remaining measurements. Interpretation. Home BP measurement is abnormal if average is more than 135 by 85 millimeters of Hg. Hypertension, page number 218. Already we have seen about it. Cardiogenic shock. Postural hypotension. BP drops are moving from supine to sitting position. Presence with false postural dizziness or lightheadedness. Measure the BP supine or seated and then ask the patient to stand up. Remeasure the BP after 1 minute of standing. Standing usually causes a slight decrease in systolic BP less than 20 millimeters of Hg and slight increase in diastolic BP less than 10 millimeters of Hg. In postural hypotension, there is usually a marked decrease in both systolic and diastolic BP. That is more than 20 millimeters of Hg drop of BP. Review medication. Stop any non-essential medication contributing to symptoms, that is night sedation, unnecessary diuretics. Optimize treatment for intercurrent heart disease, Parkinson's disease or diabetes. Advise patients to take care when standing, especially if getting up from their beds or out of hot bath or shower and after meals. Measure the subsequent BP with the patient standing. Consider the specialist referral if symptoms persist despite GP management. Hypertension. Hypertension is a major risk factor for CVD. It is normally symptomless until it causes organ damage. Prevalence increases with age. 25% of all adults and 50% of aged more than 60 years have hypertension. Management aims to detect and treat increased blood pressure before damage occurs. Causes. Unknown, that is essential hypertension in 95% of the patients, alcohol is 10% of the patients, or obesity may be contributory factors. Endocrine disease, Cushing's, both syndrome and secondary to steroids causes hypertension. Conn's syndrome, pheochromocytoma, acromegaly, hyperparathyroidism, diabetes mellitus. Renal disease, pregnancy, coarctation of aorta, all of these are causes of hypertension. Presentation, usually symptomatic and found during routine BP screening or incidentally, occasionally headache or visual disturbance. Maybe symptoms of end organ damage like LVH, TIAs, previous CBA, MI, angina, renal impairment or peripheral vascular disease. Measurement of blood pressure, already we have seen the measurement of blood pressure. Diagnosis of hypertension. BP is normally distributed continuous variable. Each 2 millimeters of Hg increase in systolic BP is associated with a 7% increased risk of mortality from ischemic heart disease and a 10% increased risk of mortality from stroke. There is no figure above which hypertension can be diagnosed definitively. Criteria currently in use. Stage 1 hypertension is clinic BP more than 140 by 90 and a subsequent daytime average ABPM or HBPM of more than 135 by 85. Stage 2 hypertension, a clinic BP of 160 by 100 and subsequent daytime average ABPM by or HBPM more than 150 by 95. Severe hypertension. Clinic systolic BP more than 180 millimeters of Hg or a clinic diastolic BP more than 110 millimeters of Hg. If the person has severe hypertension, systolic BP more than 180 or diastolic more than 110 millimeters of Hg, consider starting antihypertensive treatment immediately without waiting for the result of ABPM or HBPM. Refer for same-day specialist assessment if suspected accelerated hypertension. So BP is more than 180 or 110, plus or minus papilledema, plus or minus retinal hemorrhages. Or if you are suspecting a pheochromocytoma, labile or postural hypotension, headache, palpitations, pallor, excessive sweating. So if neither of these conditions are satisfied, then you need to immediately refer the patient for same day specialist assessment. Otherwise, you give them medicine, you start the medicine immediately. Isolated systolic hypertension. Systolic BP of more than 160 millimeters of Hg. Offer the treatment as people with increased systolic and diastolic BP. Further assessment aims to identify target organ damage. So what you will examine? Check the size of the heart sounds for heart failure, examine the fundi, look for silver wiring, AV nipping, flame hemorrhages and cotton wool spots. These are signs of hypertensive retinopathy. Blood test. Do a creatinine, electrolytes, EGFR, glucose, HbA1c, lipid profile. Consider GGT if excess alcohol is a possibility. In the urine, you check for dipstick for RBCs and protein, laboratory sample for albumin creatinine ratio. Cardiovascular risk estimation. ECG plus echo if LVH is suspected. If increased BP is not diagnosed but there is evidence of target organ damage like LVH or proteinuria, look for alternative causes. Education. Patient will not take tablets regularly. Be motivated to change lifestyle or turn up for regular checks if they do not understand why treating the BP is important. Conversely, some patients who were fit and well prior to the diagnosis will assume a sick role unless it is explained that they are well and treatment is designed to stop the illness developing. Back up a verbal information with written information that patients can take home. Reinforce information that follow up and offer opportunities for discussion. Do not forget to warn the patients about the possible side effects of any medications. Lifestyle advice. Offer a lifestyle advice to all the patients with diagnosis of hypertension and those with a family history of increased BP. Reinforce advice with written information. Offer smoking cessation advice and help decrease weight to optimum for height. Encourage regular exercise. Dynamic is best like walking, swimming, cycling. Decrease the alcohol to less than 14 units per week for both males and females. Decrease the salt intake. Aim for less than 6 grams salt per day. Increase the dietary fruit and vegetable intake. Aim for more than 5 portions per day. Decrease the excess coffee consumption and other caffeine-rich products. Encourage relaxation and stress management. Do not offer calcium, magnesium or potassium supplements as a method to decrease BP. Statin. Prescribe if hypertension complicated by CVD, irrespective of baseline cholesterol or LDL levels, you need to prescribe statin. That is primary prevention. For primary prevention in patients more than 40 years with hypertension and a 10-year CVD risk of more than 10%. So initiating an antihypertensive treatment. Stage 1 hypertension. Offer drug treatment if less than 80 years of age and more than one of the following is present. Either they have a target organ damage, established CVD, they have a renal disease, they have diabetes, or a 10-year CVD risk more than 10%. Stage 2 hypertension. Offer drug treatment to all the patients. If age less than 40 years, stage 1 hypertension and no evidence of target organ damage, CVD or renal disease or DM, consider specialist referral to exclude secondary causes of hypertension and for detailed estimation of CVD risk. So, if a patient is presenting with primary hypertension without any target organ damage or any other risk factors for hypertension, then you need to exclude secondary causes of hypertension and send them to specialist for detailed estimation of CVD risk. General rules for antihypertensive drug treatment. If a drug is not tolerated, stop the drug. Move to the next line of therapy. If a drug is tolerated but the BP target is not met, add in the next line of therapy. Where possible, recommend treatment with drugs taken only once a day and prescribe non-proprietary drugs which minimize the cost. Choice of antihypertensive drug. Figure 9.1, we will see it. Side effects. Side effects of drug treatment for hypertension are common. 40 to 50% started on an antihypertensive drug discontinue regardless of which class of drug is used. 80% of side effects are seen in the first year of treatment. Treatment targets. For non-diabetic patients and with those without CKD. Clinic BP less than 140 by 90, less than 150 by 90 if aged more than 80 years. ABPM, HBPM for patients with white coat hypertension, average daytime BP less than 135 by 85 or less than 145 by 85 Hg if aged more than 80 years. For patients with diabetes, the targets are different. So, if it is uncomplicated type 2 diabetes, less than 140 by 80. Uncomplicated type 1 diabetes, 135 by 85. If any renal, foot, eye, cardiovascular complications of type 1 or type 2 diabetes is present, you have to aim for a BP in the range of less than 130 by 80. CKD, aim for a BP less than 140 by 90 or less than 130 by 80 if CKD plus diabetes is present or CKD plus ACR is uh, of more than 70 milligrams per millimole. So if you have if the patient is having either CKD plus diabetes or CKD plus a albumin creatinine ratio of more than 70 milligrams per millimole, so in these two conditions, you have to aim for a BP less than 130 by 80. Otherwise, if he is only a CKD patient, aim for a BP less than 140 by 90. History of stroke or TIA. Or for a patient who has a history of stroke or TIA, the aim of systolic BP is less than 130 millimeters of Hg unless carotid stenosis when target is 140 by 150 of Hg. Follow-up. Regular review of patients with increased BP is essential. Review interval depends on the stability of blood pressure. After starting the treatment, review after 1 month. If BP is controlled, review after further 3 months and then every 3 to 6 months. If BP is not controlled, bring the patient back to repeat the BP reading and ask for ABPM or HBPM. Do not alter medication on the strength of a single BP reading. If increased BP is sustained, alter the medication. Review in the same way may monthly until the BP is controlled. Format for annual review. So when the patient comes for annual review, what do you check? Check for BP and look for signs of end organ failure, including annual urine test for proteinuria. Discuss symptoms and medication. Assess and treat other modifiable risk factors for CHD or CBA. Reinforce lifestyle advice. So annually, whenever the patient comes for hypertension checkup, you have to check for signs of end organ failure, including urine test for proteinuria. Referral for cardiology or general medicine. E. Emergency admission. U. Urgent. S is soon and R is routine. So accelerated hypertension is an emergency admission. Renal impairment could be either urgent, soon or routine assessment. Suspected secondary hypertension, urgent, soon or routine assessment. Patient with less than 40 years or BP difficult to treat. Step 4. That is more than 4 drugs and BP is not under control. Then routine referral. Pregnancy to obstetrician. Urgency depends on the stage of pregnancy and clinical features. So even though it is resistant hypertension, even though it is secondary hypertension or a renal impairment, these all are could be either urgent, soon or routine referrals, but otherwise accelerated hypertension, that is with an end organ damage, high BP with end organ damage is an emergency admission. Reducing or stopping treatment. Decrease BP too far, less than 120/80, may increase the morbidity. Example, as a result of postural hypertension and falls, particularly in the elderly. Do not stop medication if high CVD risk or end organ damage is present. If diastolic BP is less than 80 millimeters of Hg and systolic less than 140 consistently, consider decreasing or stopping the medication. 1 to 2 years after withdrawal of medication, 50% are normotensive, 40% stay off drug therapy permanently. Continue BP follow-up lifelong even if off medication. So this is a table and flowchart for treatment in hypertension. Step 1. Age is less than 55 years. So a person who is less than 55 years, first line treatment is ACE inhibitor therapy or ARB if ACE inhibitor is not tolerated. Step 1 for age more than 55 years or African or Caribbean family origin, any age. Offer a calcium channel blocker or thiazide-like diuretic if not tolerated. Step 2. Offer ACE inhibitor, ARB or ACE inhibitor not tolerated or of Afro-Caribbean origin plus calcium channel blocker or thiazide-like diuretic, chlorthalidone or indapamide if calcium channel blocker is not tolerated. Step 3. Ensure Step 2 treatment is at optimal best or tolerated doses. Offer ACE inhibitor plus calcium channel blocker plus thiazide-like diuretics. Now we are offering all three. In step 2 you are offering either or. Resistant hypertension. Consider adding further diuretic therapy with spironolactone 25 mg OD if potassium is less than 4.5 or a higher dose of thiazide-like diuretic if potassium is more than 4.5. Monitor sodium potassium renal function within 1 month. If diuretic is contraindicated or ineffective, consider adding alpha or beta blocker. If still uncontrolled, seek an expert advice. Choice of antihypertensive drug is figure 9.1. Beta blockers. Beta blockers are not recommended as initial therapy for hypertension. Exception is young women of childbearing potential, patient with hypertension and evidence of increased sympathetic drive, patient intolerant of with contraindications to ACE inhibitors. If initial therapy is with a beta blocker and a second drug is required, add a non-rate limiting calcium channel blocker to decrease the risk of diabetes. Hyperlipidemia. Average cholesterol level in a population is a predictor of CVD risk and dependent on diet, but on an individual level it is much poorer predictor. Only 42% who develop CVD have increased cholesterol. However, lowering the LDL and raising the HDL is thought to reduce progression of coronary atherosclerosis, whatever the age of the patient, and is a valuable tool for both primary and secondary prevention of CVD. Cholesterol testing. Cholesterol is a fatty substance measured by the body, mainly the liver, which manufactured by the liver, which plays a vital role in functioning of cell membranes. Cholesterol levels are checked with a non-fasting sample. A lipid profile includes HDL cholesterol, high density lipoprotein. Low levels are associated with increased CVD risk. Non-HDL cholesterol, including LDL and VLDL. High levels are associated with increased CVD risk. Triglycerides, independent risk factor for CVD. Ratio of total cholesterol to HDL used to predict the risk. No threshold. The higher the ratio, the greater the risk. High risk if less than 6. Consider the family dyslipidemia. If any patient with total cholesterol more than 7.5 millimoles per liter and FH of premature family history of premature coronary vascular disease, refer for specialist assessment if total cholesterol is more than 9 or non-HDL cholesterol is more than 7.5 regardless of family history. Management of raised triglycerides. If triglycerides are more than 20 millimoles per liter, refer for urgent specialist review if not as a result of excess alcohol or poor glycemic control. If TGs are 10 to 20 millimoles per liter, repeat the triglyceride measurements with a fasting test after an interval of more than 5 days but in less than 2 weeks. Review the potential secondary causes of hyperlipidemia, which are noted in box 9.1. Seek specialist advice if TGs remain more than 10 millimoles per liter. If TGs are 4.5 to 9.9 millimoles per liter, CVD risk may be underestimated by risk assessment tools. Optimize management of other CVD risk factors. Seek specialist advice for increased TGs plus non-HDL cholesterol more than 7.5 millimoles per liter. Lipid screening. In the UK, the NHS provides health checks every 5 years for those aged 40 to 74. These include a lipid profile. Potential problems with this strategy. The most needing in health check are least likely to attend. There may be less inclination to eat a healthy diet if cholesterol levels are known to be normal, and those with increased cholesterol levels may assume a sick role. So blood cholesterol concentration is not steady over time. In 1 in 4 increased cholesterol levels are normal on repeat testing. If lipid levels are high on screening, repeat with attention to diet. Only treat with statin if lipids remain high despite low cholesterol diet and a 10-year cardiovascular risk is more than 10%. So not every high or abnormal lipid profile should be treated with statins. Only if the lipids are high even after low cholesterol diet or a 10-year cardiovascular risk is more than 10%, you will start a statin. Opportunistic screening. Offer if other risk factors for CVD or signs of increased cholesterol are present. Example, corneal arcus in less than 50 years old person, xanthelasmia and xanthomata. Then you do opportunistic screening. Calculating cardiovascular risk. Always consider the cholesterol in the context of other risk factors for CVD. Secondary hyperlipidemia. High lipid levels are a consequence of other condition, box 9.1. Secondary causes of hyperlipidemia. So, secondary causes of hyperlipidemia. Drugs. Steroids, beta blockers, thiazides, COC pills, isotretinoin, antipsychotics, tamoxifen, antiretrovirals. Obesity, diabetes, alcohol, smoking, pregnancy, hypothyroidism, renal failure, nephrotic syndrome, RA or SLE, HIV, cholestasis, Cushing syndrome, porphyria, myeloma, lipodystrophies, glycogen storage disorders. So all of these are secondary causes of hyperlipidemia. Treatment of hyperglycemia in diabetes reduces secondary hyperlipidemia. Patients with hypothyroidism should receive adequate thyroid replacement before assessing the need for lipid lowering treatment. Correction of hypothyroidism may resolve the lipid abnormality, and untreated hypothyroidism increase the risk of myositis with statins. So whenever sometimes you will come across that in your patients presenting with first time diagnosis of hyperglycemia, diabetes, you also see that lipid profile is raised. That could be because of secondary hyperlipidemia. So never treat on the first instance of diagnosis of diabetes, never treat hyperlipidemia with a statin. First, let the sugar levels come back to normal and then you can treat hyperlipidemia if it persists. Non-drug therapy. Offer to all the patients with increased cholesterol, increased CVD risk and those with diabetes or a family history of CVD, CHD. Reinforce advice with written information. What is the non-drug therapy? It's dietary modification. Decrease the intake of fats to less than 30% of total energy intake. Saturated fats to less than 7% and decrease the cholesterol intake to less than 300 milligrams per day. Replace the saturated fat with monounsaturated or polyunsaturated fats. If cholesterol level is more than 5 millimoles per liter, low cholesterol diets result in decrease in cholesterol of 8.5% at 3 months. Eat more than 5 portions of fruits and vegetables per day. 4 to 5 portions of unsalted nuts or seeds or legumes per week and more than 2 portions of fish per week, including one of the oily fish, maximum 2 portions of oily fish per week if pregnant, and choose whole grains and reduce sugar. Decrease the alcohol intake to less than 14 units per week and less than 3 to 4 units per day in females or less than 2 to 3 units per day in males. Maximum weight is less than to maximum. Weight, decrease the weight. In patient with a BMI of more than 30 kg per meter square, weight should be reduced of 10 kgs. 7 weight reduction of 10 kgs causes 7% drop in non-HDL cholesterol and 13% increase in HDL cholesterol. So reducing the weight itself will normalize your cholesterol levels. So increase physical activity, enhance cholesterol lowering effects of diet and weight loss. Advise 150 minutes of moderate or 75 minutes of vigorous exercise per week plus or minus muscle strengthening exercises of 2 times a week plus muscle strengthening exercise of 2 times per week. Stop smoking. So plant sterols or stanol esters inhibit the cholesterol absorption and can decrease serum cholesterol with average diet by 10%. Decrease the effect of if already on low fat diet. Avoid on a lipid lowering medications, diabetes, type 1 or type 2 or CKD. So avoid plant sterol or stanol esters if we are already on a lipid lowering medication, diabetes or CKD. Who should be treated with statin? Consider statin therapy for primary prevention if the patient is more than 85 years, if appropriate, 10 years CVD risk is more than 10%, eGFR is less than 60 milliliters per minute per meter square, or albuminuria is present, type 1 diabetes plus age more than 40 years, or type 1 diabetes for more than 10 years, or established nephropathy or other CVD risk factors are present. Start the treatment after optimizing lifestyle intervention and treatment of other modifiable risk factors or secondary causes of dyslipidemia. Secondary prevention. If history of CVD, start treatment immediately irrespective of initial cholesterol levels. Factors to consider before starting a statin. Discuss the risk versus benefit. Consider other comorbidities, polypharmacy, general frailty, and life expectancy before deciding to prescribe. Contraindicated in a pregnancy and breastfeeding, and for those with active liver disease, that is transaminases at more than 3 times the upper limit of normal. So initially, before starting a statin therapy, you need to take a baseline LFT testing. Drug interactions. Statins increase the effect of warfarin. There is an increased risk of myositis when statins are taken along with other lipid lowering drugs, macrolide antibiotics, example, erythromycin, antifungals like ketoconazole, amiodarone, calcium channel blockers, HIV protease inhibitors, danazol, and cyclosporin. Diet restrictions. Avoid grapefruit if taking atorvastatin, simvastatin or lorvastatin, and cranberry juice if fluvastatin only. Baseline assessment before starting a statin. So what are the tests you have to do before you are starting a patient on statin? Smoking status, alcohol consumption, blood pressure, BMI, lipid profile, liver function tests like transaminases. If transaminases are more than 3 times the upper limit of normal, then you should use statins. Statin is contraindicated. And HbA1c, renal function test, eGFR and TSH. So all of these you have to assess before starting a statin. Only measure creatinine kinase level if there is history of unexplained persistent generalized muscle pain. If creatinine kinase is less than 5 times the upper limit of normal, start a statin at lower dose. If it is more than 5 times the upper limit of normal, recheck after 7 days. If it is more than 5 times the upper limit of normal, do not start a statin. Starting dose. Statins are most effective when taken in the evening. Use a high intensity statin to decrease the LDL by more than 40%. Primary prevention. Start atorvastatin 20 after optimizing lifestyle intervention and treatment of other modifiable risk factors. Secondary prevention. Start atorvastatin 80 mg immediately. Rosuvastatin 10 to 40 mg is an alternative. Simvastatin 80 mg, also high intensity statin, should not be commenced due to increased risk of myopathy. Target lipid levels. Aim to decrease the non-HDL cholesterol by more than 40% from baseline. Follow-up. Recheck lipid profile in 3 months. If the target is not met, promote lifestyle measures and check concordance. Increase the dose if tolerated or not on maximum dose. Check the liver function test every 3 months and 1 year after initiating a statin or changing the dose. Do not recheck again unless clinically indicated. Do not routinely check the CK levels only if there is muscle pain. Benefits of statins. Decrease the CVD risk overall by 25%. In general, the higher the risk of CVD at baseline, the greater the benefit of statins. Therefore, all the patients with established CVD benefit for statin treatment. Established CVD benefit for statin treatment in terms of decreased CVD risk and greatly outweighs the risk. Primary prevention. As overall risk is lower in primary prevention, the benefit of statin treatment is not so clear-cut. Decision aids may be helping the patients to decide whether or not they wish to take a statin. Options. NICE. NICE provides a paper-based decision aid in tools and resources section of its lipid modification guideline. QRISK-3 and JBS3 risk calculator tools can both be used to graphically demonstrate the risk reduction likely for individual patients from modification of lifestyle factors and or taking statins. The adverse effects of statins. Overall NNH for high intensity statin therapy is 63. If unable to tolerate a statin, consider a reduced dose or prescribe an alternative statin or ST. Specific side effects. Myositis. Most important adverse side effect 11 in 1 lakh persons years. Risk is increased if elderly or alcohol misuse. Usually arises less than 6 months after starting treatment. Consider other causes if later. Maybe genetic predisposition. Ask the patients to report unexplained muscle pain or weakness. Check the creatinine kinase if more than 5 times the upper limit of normal. Withdraw the therapy. Peripheral neuropathy. Stop statins and seek specialist advice if unexplained peripheral neuropathy develops. Abnormal liver function. Discontinue if serum transaminases increase and remain at more than 3 times the upper limit of normal. So that means there should be a persistent increase. So you have to do at least 2 tests to stop statin. Diabetes. Increased risk of type 2 diabetes. Consider screening with HbA1c. Alternative lipid lowering treatments. Do not offer fibrates or nicotinic acid or bile acid sequestrants or omega-3 fatty acid for prevention of CVD. STMB may be used if statin is contraindicated or not tolerated or combined with low-dose statin to achieve target cholesterol levels. Familial dyslipidemia. Familial dyslipidemia or familial hypercholesterolemia. In these cases, you need to screen the first degree blood relatives aged more than 18 years every 5 years with fasting lipids if family history of familial hyperlipidemia is present and or family history of premature coronary vascular disease is present, that is less than 55 years in males, females or less than 65 years in females. Less than 55 years in males and less than 65 years in females. Exclude secondary causes of hyperlipidemia as in box 9.1. Refer if a total cholesterol is more than 7.5 millimoles per liter or FH of premature CVD, or a total cholesterol is more than 9 millimoles per liter and non-HDL cholesterol is more than 7.5 millimoles per liter, or TGs is more than 10 millimoles per liter, or repeat fasting sample urgently if more than 20 millimoles per liter. So these are the conditions in which you refer a patient suspecting familial dyslipidemia, familial hypercholesterolemia. Common types of familial dyslipidemia. Polygenic hypercholesterolemia. Polygenic, most common, presence with family history of premature CHD plus increased total cholesterol more than 6.5 millimoles per liter. Familial combined hyperlipidemia. It is also polygenic, affects 0.5 to 1% of population and 15% have MI less than 60 years. It is associated with obesity, insulin resistance, diabetes, increased BP, xanthelasma, corneal arcus and premature ischemic heart disease. Increased cholesterol, total cholesterol, that is 6.5 to 10 millimoles per liter. Increased TGs 2.3 to 12 millimoles per liter. Familial hypercholesterolemia. Autosomal dominant, it is heterozygous form, affects 1 in 500 individuals. Associated with tendon xanthomata and family history of premature ischemic heart disease. increased LDL more than 4.9 millimoles per liter, increased total cholesterol more than 7.5 millimoles per liter, and normal triglycerides. So this is the classical familiar hypercholesterolemia, which is the autosomal dominant condition. Familial hypertriglyceridemia. It is also autosomal dominant. It affects 1% of the population and near about 5% having MI less than 60 years. Associated with diabetes, obesity, gout, eruptive xanthomas, pancreatitis, normal or slightly increased total cholesterol with increased triglycerides 2.3 to 10 millimoles per liter. So there are different types of familial dyslipidemias. One is polygenic inheritance hypercholesterolemia, familial combined hyperlipidemia, familial hypercholesterolemia, familial hypertriglyceridemia. Both of these are autosomal dominant. Angina. Angina affects 8% of the males and 3% in females in the UK. Incidence increases with age. Coronary artery disease is the most common cause. Rarer causes include HOCM, valve disease, hypoperfusion during arrhythmias, arteritis, anemia, or thyrotoxicosis. Mortality, usually sudden death, acute coronary syndrome, or left ventricular failure, is 0 to 5.5 to 4% per year, and it is doubled if coexistent left ventricular dysfunction is present. Chest pain of recent onset, presentation of stable angina. Diagnosis is usually made on the history. Pain, episodic central crushing or band-like chest pain that may radiate to the jaw, the neck, or one or both the arms. Pain in the arms and neck may be the only symptom. Ask about the frequency, severity, duration, and timing. Precipitating and relieving factors, precipitated by exertion, cold, emotion, and or heavy meals. Pain stops with rest or GTN spray. So angina is precipitated by exertion, when it is excessively cold, when there is excess emotions, or after a heavy meals. Pain stops with rest or GTN spray. Associated symptoms. Pain may be associated with palpitations, sweating, nausea, or breathlessness during the attacks. Presence of risk factors like smoking history, family history, history of other vascular disease, CVA, TIA, and peripheral vascular disease. Examination. On examination in case of angina, there are usually no physical signs, although anemia may exacerbate the symptoms. Check the BMI and BP. Look for murmurs, especially ejection systolic murmur of aortic stenosis, and evidence of peripheral vascular disease or carotid bruits, especially in patients with diabetes. First line investigations in a patient with angina. You did FBCs, fasting blood sugars, blood sugars, full blood count, fasting lipid profile. Consider checking ESR to exclude arteritis and TFTs if suspicious thyrotoxicosis. A 12-lead ECG provides information on the rhythm, presence of heart block, previous MI or myocardial hypertrophy or ischemia. A normal ECG does not exclude a coronary artery disease, but an abnormal ECG identifies those at a higher risk of cardiac events in the next year and consider referral for further investigation. Differential diagnosis of chest pain, we'll see in page 1065. Referral for patient with suspected stable angina. For patients with new onset intermittent chest pains, refer to rapid access chest pain clinic for prompt specialist assessment to confirm or refute angina, perform appropriate investigations like a cardiac MRI, provide information on the treatment options available during the merits, including the merits of revascularization for the individual. Patients with pre-existing cardiac disease, example a previous MI, valve disease, cardiomyopathy, are often excluded from rapid access chest pain clinic referral to cardiology direct. Management of patient with stable angina. Provide information about angina and its treatment. Driving. As far as driving is concerned, Group 1 license, no need to inform DVLA. The patient must not drive when symptoms occur at rest, with emotion, or at the wheel. Group 2 license notified the DVLA must not drive when the symptoms occur. License is revoked if the symptoms continue and restored if angina. There is no angina for more than 6 weeks plus DVLA function test requirements are met. Occupation may be unable to undertake heavy work, give advice or support. Special rules apply to some occupations. Example, a merchant seaman, airline pilots. Advice to consult occupational health. Non-drug treatment aimed at secondary prevention of congestive non-drug treatment is aimed at secondary prevention of coronary heart disease like smoking cessation, hypertension control, check the BP and treat if more than 140 by 90, diet, advise a healthy diet, oily fish, low cholesterol diet, increase fruit and vegetable diet, decrease in salt, and if obese, aim to decrease the weight until the BMI is less than 25 kg per meter square. So decrease the alcohol to less than 14 units per week, and so there is a particular thing like less than 3 to 4 units per day in males or less than 2 to 3 units per day in females, but total units should be less than 14 units per week. Exercise, increase the aerobic exercise with the limit set by the disease state. Consider referral for cardiac rehabilitation. Treat diabetes, treat any underlying diabetes mellitus. Cardiac rehabilitation may be helpful for patients with angina or after surgery. Drug treatment. Drug treatment, page 228, referral to cardiology. So these are the E is admit, U is urgent, S is soon, and R is routine. So when there is an unstable angina and rapidly progressive symptoms, you admit. Aortic stenosis with angina is urgent. Angina falling in MI, urgent or soon. Abnormal ECG at diagnosis, urgent or soon. Angina is not controlled by medication with 2 drugs, urgent, soon or routine. If diagnosis is in doubt, soon or routine. Strong family history, routine. Other factors, example occupation affected, routine. Unstable angina, pain on minimal or no exertion, pain at rest may occur at night, or angina which is rapidly worsening in intensity, frequency or duration. Incidence 6 in 10,000 years, and 50% suffer MI in less than 1 month. Management. Whenever you find a case of unstable angina, the management is urgent referral to cardiology, admit if attacks are severe and occur at rest or last more than 10 minutes even with a GTN spray. Surgical intervention. Consider referral for coronary revascularization bypass with bypass surgery, CABG, or PCI if symptoms are not controlled with anti-anginal drug intervention, that is 2 drugs. Both procedures decrease the symptoms, but CABG confers survival advantage if diabetes, age is more than 65 years, left anterior descending artery disease, or complex three vessel disease. So, CABG provides survival advantage if uh, it done in patient with diabetes, age more than 65 years, or left anterior descending artery disease, or a complex three vessel disease is present. Prince vessel angina, variant angina, angina at rest resulting from coronary artery spasm. ECG shows ST elevation. Refer to cardiology to exclude MI and atherosclerotic angina. GTN elevates immediate episodes. Calcium channel blockers are used to prevent angina. In this case, cardiac syndrome X. Ongoing angina symptoms despite normal coronary angiography. Treat with beta blockers or calcium channel blockers if effective, but not secondary preventive agents. Drug treatment for angina. Symptom control. As required medicine is GTN spray. Is used as required symptom relief for angina. Advise 1 to 2 puffs as needed in response to pain before engaging in activities that bring pain. Warn about the side effects, flushing, headaches, lightheadedness. Sit down or find something to hold on to if this occurs. If used for chest pain, Advise patients to repeat the dose of GTN after 5 minutes if the pain has not gone. If the pain has not gone after 5 minutes after the second dose, advise to call emergency ambulance. Regular treatment. Drugs for regular symptomatic treatment. Within any drug class, use the cheapest preparation that the patient can tolerate, will comply with, and with control symptoms. Which control symptoms? Assess response every 2 to 4 weeks after initiating changing drug therapy. First line agent is beta blocker. For in angina, first line agent is beta blocker or a calcium channel blocker. The choice depends on comorbidities, contraindications, or patient preference. If treatment is ineffective or not tolerated, switch to whichever first line agent has not been tried or combine a beta blocker and a dihydropyridine calcium channel blocker. Alternate regular treatments include the long-acting nitrates, ivabradine, nicorandil, and ranulazine. Consider monotherapy if both first-line agents, beta blockers and calcium channel blockers are contraindicated or not tolerated, in combination with the first-line agent if symptoms are not controlled with one of the first-line agent alone or with first-line agent is contraindicated or not tolerated, as a third anti-anginal agent if the symptoms are not controlled with two anti-anginal drugs and the person is either not suitable for CABG or PCI or is awaiting a CABG or PCI. So the indication for CABG or PCI in angina is when the symptoms of angina are not controlled with two anti-anginal drugs. So in this case, when two anti-anginal drugs, the symptoms are not controlled, then add the third drug only if the person is either not suitable for CABG or PCI or is awaiting a CABG or PCI. Secondary prevention. Aspirin decreases the mortality by 34%. Unless contraindicated, give 75 milligrams OD to all patients with angina. Consider clopidogrel if aspirin is intolerant. Statin. A reduction in total cholesterol and LDL by 25 to 35% results in reduction in CHD mortality by 25 to 35%. Trial data suggest all patients with proven CHD benefit from statin treatment irrespective of initial cholesterol concentrations. ACE inhibitors significantly reduce the cardiovascular deaths, relative risk 0.83 and all-cause mortality relative risk 0.87 even in the absence of left ventricular dysfunction. So, secondary prevention in angina, you have to give aspirin, you give the patient a statin, it has a benefit, and you give ACE inhibitors, decrease the overall cardiovascular deaths and left ventricular dysfunction, mortality. Drug treatment of angina. Beta blockers may accumulate in patients with renal failure, decrease the dose, effective for symptom control to prevent vascular events. Check fully beta blocked by monitoring the heart rate. Resting heart rate less than 65 beats per minute. Post exercise, example walking up 2 flights of stairs, heart rate less than 90 beats per minute. How do you check? See, if a person is fully beta blocked, then the resting heart rate will be less than 65 beats per minute. And post exercise, that is walking up 2 flights of stairs, the heart rate should be less than 90 blocks bpm beats per minute. Further, increase in dose once adequately beta blocked are usually unhelpful. So once this level is reached, you don't need to increase the dose. So it is unhelpful. One, the patients, and even after this, they are fully beta blocked, the symptoms are not controlled, then you add another drug. When beta block are usually warn patients not to stop suddenly or run out. If the patient needs to stop the drug, tail off over 4 weeks. In patients with asthma or COPD in whom beta blockage is essential, use cardioselective beta blockers like atenolol, bisoprolol, metoprolol, nebivolol with care. In patients with left ventricular failure, start at a very low dose and titrate dose over weeks or months. Dihydropyridine calcium channel blockers. Example, amlodipine and felodipine. All equally effective in symptom control. No evidence of cardioprotective effect. Contraindications are vary. Do not use if aortic stenosis is present. So, dihydropyridine calcium channel blockers are contraindicated in aortic stenosis and angina. Less than 1 month old post MI, or uncontrolled heart failure except with a specialist advice. Rate limiting calcium channel blockers like diltiazem and verapamil. Contraindications: avoid if there is a heart block or a heart failure. Do not combine with beta blockers. Long-acting nitrates. Isosabide mononitrate. Oral or patch preparations doses less than 10 milligrams per 24 hours are available. Start with a low dose and increase as tolerated. Side effects are common. Side effects are headache, postural hypotension, dizziness. Wear off with use. Reflex tachycardia may decrease the coronary blood flow and worsen angina. Tolerance. Many patients rapidly develop tolerance with decreased therapeutic effect. To avoid this, allow nitrate-free period of 4 to 8 hours per day overnight by removing patches at night or giving the second dose of ISMO at 4 p.m. Contraindications: HOCM, aortic stenosis, constrictive pericarditis, mitral stenosis, severe anemia, closed angle closure glaucoma. So, your long-acting nitrates are contraindicated in HOCM, aortic stenosis, constrictive pericarditis, mitral stenosis, severe anemia, and angle closure glaucoma. Potassium channel activators or nicorandil. Headache is common, usually transitory. Contraindications are left ventricular failure and hypotension. Ivabradine lowers the heart rate by its action on the sinus node. Contraindications: avoid if the heart rate is less than 60 beats per minute, heart block, or heart failure. Ranolazine affects sodium dependent calcium channels. Contraindications: renal or liver failure. Use with caution if CCF, congestive cardiac failure, or weight is less than 60 kgs. Post myocardial infarction. So, after a myocardial infarction, acute coronary syndrome, modification of risk factors after MI. Secondary prevention. Cholesterol. All with proven CVD, CHD coronary heart disease benefit from decreasing cholesterol and LDL irrespective of initial cholesterol level. A reduction of 25 to 35% using statin therapy results in 25 to 35% decrease in CHD mortality. Serum cholesterol levels less than decrease after MI and remain decreased for several weeks. Beta blockers. So after MI, you need to give statins and beta blockers. Unless contraindicated, start an oral beta blocker soon after an MI and titrate to target to maximum tolerated dose. Continue for 12 months or indefinitely if left ventricular failure is present. Prevent deaths. 12 Near about 12 deaths per thousand treated per year. If contraindicated, consider a rate-limiting calcium channel blocker, diltiazem or verapamil instead. So you need to keep the heart rate at a minimum and cholesterol levels as less as possible after an MI. So that is modification of risk factors after MI, and then you give a ACE inhibitor which decreases the myocardial work and deaths less than 1 month post MI by 5 per treated. Titrate to target or maximum tolerated dose in 4 to 6 weeks. Survival advantage is sustained more than 1 year even if the treatment is not continued. Effects are greater for patients with heart failure at presentation. Long-term ACE inhibitor trials show decreased mortality for all patients. If ACE inhibitors are not tolerated, use an ARB. Antiplatelet medication, aspirin. Starting aspirin 75 milligrams OD less than 24 hours after MI prevents 80 vascular events over the next 2 years in 1,000 patients treated. Unless contraindicated, continue lifelong. Aspirin should be continued lifelong unless contraindicated. Clopidogrel 75 milligrams OD prescription in addition to aspirin for 12 months period if it's a non-ST elevation MI, NST EMI or unstable angina. 1 month following an ST elevation MI with no coronary stenting, 3 months following ST elevated MI with a bare metal stenting, and 12 months following STMI with a drug-eluting stent. Alternatives to clopidogrel. In certain circumstances, new antiplatelet agents like prasugrel or ticagrelor may be used in combination with aspirin after ACS and PCI. Anticoagulation. Occasionally required if atrial fibrillation is present, left ventricular aneurysm, or if clopidogrel aspirin is not tolerated. Drug treatment of angina, we have already seen beta blockers, CCBs, and then ivabradine, ranolazine, and other drugs. Heart failure, left ventricular dysfunction. Consider treatment with an aldosterone antagonist, example spironolactone 25 milligrams OD, increase in less than 1 month to 50 milligrams OD, starting 3 to 14 days after the MI. If symptoms or signs of heart failure and left ventricular systolic dysfunction, ejection fraction less than 0.4. Cardiac rehabilitation decreases the risk of death by 20 to 25% provided specialist multidisciplinary teams. Components include psychological support, information about coronary heart disease, structured exercise program, and modification of risk factors. Advice to provide after discharge. Physical activity. Advise gradual increase in activity. Ensure goals given match those given by local cardiac rehabilitation guide. So, after 2 weeks, just stroll in the garden or the street. From 2 to 6 weeks after the event, walk half mile per day, aiming to increase to 2 miles a day by 6 weeks. From 6th week onwards, increase the speed of walking, aim 2 miles in less than 30 minutes duration. Sexual activity. Resume as comfortable, usually after more than 4 weeks. A leaflet is available from British Heart Foundation. Return to work. Sedentary workers 4 to 6 weeks after an uncomplicated MI. Light manual workers 6 to 8 weeks after an uncomplicated MI. Heavy manual workers 3 months after uncomplicated MI. Psychological effects. Near about 50% are depressed 1 week after an MI, 25% after 1 year. Educate about CHD. Check for depression. Counsel and treat as needed. Driving Group 1 license. No need to notify the DVLA in case of an MI. Stop driving. Restart after 1 week if successful PCI is done and no other revascularizations planned in less than 4 weeks. Otherwise, driving can restart 4 weeks after the event. Driving Group 2 license. Inform the DVLA license is revoked, reinstated after more than 6 weeks if LV ejection fraction is more than 40% and DVLA function test requirements are met. Flying. Most airlines will not carry passengers for 2 weeks after an MI and then only if able to climb one flight of stairs without difficulty. Ongoing GP follow-up. Monitoring of health. So what do you do when the patient comes after an MI to you for follow-up? Monitor health. Continue regular reviews at least lifelong, annually. Check for symptoms and signs of cardiac dysfunction like breathlessness, palpitation, angina, depression, and carer stress. Monitoring drug therapy. Ongoing prescription of drugs, monitoring compliance, side effects, changing medication circumstances, best practice, alter. Secondary prevention. So, in a patient with an MI, you have secondary prevention measures are smoking cessation, decrease the risk by 50% over 15 years, hypertension, check the BP and treat if more than 140/90, diet, Mediterranean style diet, low cholesterol, increase fruits and vegetables, decrease salt, and if obese, aim to reduce the weight until the BMI is less than 25 kg per meter square. Do not advise oily fish to decrease the risk of further MI, but don't no evidence of harm. Decrease alcohol intake. Increase exercise, aerobic activity. Diabetes. Treat an underlying diabetes mellitus. Reinforce information given during cardiac rehabilitation. Dressler syndrome or post-MI syndrome. What is this? It develops 2 to 10 weeks after an MI or a heart surgery as a result of autoantibodies to the heart muscle. Presents with recurrent fever, chest pain, plus or minus pleural or pericardial effusion. Management. Refer urgently to cardiology advice. Treatment is with steroids and NSAIDs. So we are done for today's class and we are at page number 232. We'll continue from page number 232 tomorrow. Thank you, friends. Good day.